Imagine you are diligently providing treatment to a patient when suddenly the patient gasps for air and complains of respiratory distress. This is a moment of critical importance as it signals a potential oxygen deficit in the body. To understand the urgency, consider this. The human brain, being one of the most metabolically active organs in the body, consumes 3.5 ml of oxygen per 100 gram of brain tissue every minute. The average man weighs 70 kg and consumes around 250 ml of oxygen per minute at rest, while the average human brain, which is around 2% of the total body weight, that is 1400 grams, consumes around 49 ml of oxygen per minute, that is 20% of the total body oxygen consumed. Hence, it becomes very crucial to immediately manage any such condition like respiratory distress that may lead to reduced oxygen supply in the body. Hello everyone, welcome to the series on medical emergencies in dental practice. Today I will be discussing about acute asthmatic episode, which is one of the most common cause of respiratory distress. An acute asthmatic episode occurs in patients with history of asthma and is characterized by shortness of breath or wheezing. It may occur due to spasm of the respiratory smooth muscles, which is reversible in nature, or airway inflammation with edema and mucus hypersecretion, which is irreversible in nature. So what happens is, under normal conditions, the tone of bronchial smooth muscles is regulated by the vagus nerve, which causes constriction, and the sympathetic nervous system, which causes bronchodilation. In asthmatic patients, bronchi becomes highly reactive with exaggerated response to normally non-noxious stimulus and constriction of bronchial smooth muscles. This causes narrowing of the bronchi and a restricted exchange of air in the lungs. So, as less air passes through the airway, there is respiratory distress and shortness of breath. Also, the air passing through the constricted bronchus creates a sound described as wheezing. There is trapping of air within the lungs, which makes the patient sit up and use accessory muscles of respiration so as to lift the rib cage and generate high negative intrapleural pressure. The levels of catecholamines in the blood increases, leading to rise in blood pressure and anxiety. In the dental setting, acute asthmatic episode commonly occurs during or after injection of local anesthetic or during a stimulating dental procedure such as extraction or induction and recovery from sedation. The patient will complain of a feeling of thickness or congestion in the chest and cough with or without sputum. There will be shortness of breath and patient will prefer sitting erect or standing up. Wheezing can be heard during both inspiration and expiration. There will be tachypnea, that is more than 20 breaths per minute, and increased blood pressure and heart rate, sometimes over 120 beats per minute. The patient will show increased anxiety and apprehension. In addition, respiratory distress can lead to several associated symptoms. These include diaphoresis, agitation, somnolence or confusion, soft tissue retraction in the intercostal and supraclavicular regions, and nasal flaring. If the condition worsens and bronchospasm progresses, there may be hypoxia, cyanosis, and an eventual loss of consciousness. Now coming to the management part. The management can be described in 4 steps. Step 1. Termination of all dental procedures. Step 2. Positioning of the patient in semi-erect or erect position, whichever is more comfortable. Step 3. Assessment of circulation, airway and breathing and monitoring vital signs. And step 4 involves definitive care with administration of oxygen and emergency drugs. One important point to note here is that oxygen should be administered with caution in patients of COPD presenting with respiratory distress. The emergency drug to start with are bronchodilators. Among the beta-2 adrenergic agonists, albuterol is the bronchodilator of choice. It is selective and fast-acting with long duration of action and minimal side effects. It is also recommended for the treatment of acute asthma in patients with concomitant medical problems. The best route of administration is via inhalation of aerosolized spray, as it has similar onset of action within 15 minutes but minimum systemic absorption and side effects. If possible, the patient should be allowed to self-administer using their own inhaler or from the emergency kit. Repeated doses should be administered with caution to avoid any overdose. If the signs and symptoms are relieved, the patient should be monitored in the dental office until recovery, and medical specialists should be consulted before starting any further treatment. But if the signs and symptoms continue, and if 3 doses of aerosolized bronchodilator fails to resolve the acute episode, 0.3 ml of 1:1000 epinephrine should be given IM or subcutaneously, and IV fluids should be started. Epinephrine is contraindicated in asthmatic patients with high blood pressure, diabetes mellitus, hyperthyroidism, and ischemic heart disease. If the signs and symptoms are still not relieved, medical help should be called for. Administer theophylline 250 mg IV over 10 minutes and hydrocortisone 100 mg IV, and transfer the patient to an emergency care facility. Systemic corticosteroids are proven treatment for the inflammatory component of asthma, and the onset of their anti-inflammatory effect is 6 to 12 hours. Glucocorticoids are considered important in the management of severe acute asthma for patients aged more than 40 years. Asthmatic children are often relieved when removed from the treatment environment. If not, then a bronchodilator such as albuterol should be administered, and if this also fails, using epinephrine should be considered at a dose of 0.15 mg for weight up to 30 kg to 0.3 mg for weight more than 30 kg. At last, some important points to note. Patients with chronic obstructive pulmonary disease may also present with respiratory distress while undergoing dental treatment. This is of particular concern since if excessive oxygen is administered to a COPD patient, it may lead to fall in respiratory rate, cyanosis, and apnea. This is mainly because COPD patients become accustomed to high arterial carbon dioxide levels and use low oxygen levels as the primary stimulus to drive respiration. They rely on accessory muscles of respiration for breathing and experience breathing difficulty when placed in supine position, as it interferes with the use of these muscles. The ASA physical status classification places well-controlled and easily managed asthma under ASA 2. Acute asthma precipitated by stress or exercise or requiring hospitalization for treatment comes under ASA 3, and ASA 4 consists of patients with asthmatic symptoms present at rest. That was all about acute asthmatic episode. However, it is recommended to refer the updated and standard guidelines regularly to keep yourself up to date with the emergency protocols. In the upcoming video, I will take on another medical emergency and its management. Till then, if you found the video helpful and informative, then do like the video, share it with your friends, and subscribe the channel for more such videos. Also, you can download our app for more details and notes on dental and medical topics.